Welcome to part 2 of Cardiovascular Lecture 6, The Heart is a Pump, Cardiac Cycle. In part 1 of the lesson, we considered the pressures and volumes in the left side of the heart over the cardiac cycle. A similar sequence of events occurs in the right heart, but the pressures are much lower. The right ventricle is a thin-walled, much less muscular pump that is designed to pump volume at low pressure. It is not devised to pump against a high afterload. And this is because it just doesn't need to. The right heart pumps blood through just one organ, the lungs, and the pulmonary vasculature is unusual in that it has a very low resistance. And as a consequence, the right heart can pump the same volume of blood as the left heart, but at pressures that are 4 to 5 times lower. Let's illustrate this by introducing a very common procedure now carried out by an interventional cardiologist called cardiac catheterization. It's done in a cath lab like the one shown here. The patient is awake but lightly sedated, and the procedure causes little or no pain. A long flexible tube called a catheter is threaded up the femoral vein, sometimes the right jugular vein, until it reaches the heart. The tip of the catheter is equipped with a pressure transducer, and behind it is a tiny balloon that can be inflated. Once the catheter is advanced into the right atrium and threaded across the tricuspid valve, the balloon is inflated, causing the tip to float up across the pulmonic valve and into the pulmonic artery. The catheter is further advanced until the balloon becomes wedged into a small pulmonary artery. And the pressure recorded ahead of the balloon at that position closely reflects the pressure in the left atrium. Why might this be so? Recall that the pulmonary circulation is a very low resistance circuit. The blood vessels in the lung offer very little resistance to flow. So the pressure recorded on the arterial side of the pulmonary vasculature are very closely reflective of the pressures on the venous side, extending all the way into the left atrium. We'll learn that the left atrial pressure is extremely important to the cardiologist because this is the driving force for ventricular filling, and this is key to the diagnosis of diastolic and systolic forms of heart failure. Although not shown here, it is also possible, if necessary, to thread a catheter through a systemic artery and enter into the left side of the heart. So here are the pressures recorded by the pressure-sensitive tip of the catheter as it goes through the right atrium, right ventricle pulmonary artery. Notice that the pressures in the right atrium are quite low, only about 5 torr, and we see the characteristic ACV transients that we discussed in the left atrium. At this point, the pressure-sensitive tip of the catheter is advanced into the right ventricle, and we start to see the excursions of pressure from 0 to about 25 torr. So this is the right ventricle going through one cardiac cycle. Notice that these pressures are about 1/4 to 1/5 those seen on the left side of the heart. So here are 3 cardiac cycles. At this point here, the balloon near the tip of the catheter is inflated, and the catheter floats up across the pulmonic valve into the pulmonary artery. And we record this pressure transient here. And notice that it even has a little diacritic notch, which is characteristic, that tells us that this is an arterial pulse. Okay, so this would be the pulse pressure of the pulmonary artery. It goes from 25 to about 10 millimeters mercury. Now, the catheter is further advanced at this point here, and eventually the catheter becomes wedged in a small pulmonary artery. And since the balloon is inflated, the pressures are only recorded forward of the catheter. And because there is very little resistance in the pulmonic circuit, the pressures recorded on the arterial side are very similar to those recorded on the venous side of the lung. And so this pulmonary artery wedge pressure, as it is called, very closely reflects the left atrial pressure. And we see those transients here. Notice that the left atrial pressure is a little bit higher typically than the right atrial pressure. It might go from 8 to 11 millimeters mercury. So far, I've given you the impression that the left and the right chambers of the heart contract in perfect unison, but this isn't quite correct. There is some asynchrony. And this is a complex diagram, and I'll tell you the part that I want you to know in just a moment. Notice that the right atrium contracts before the left simply because it's closer to the SA node. and the left ventricle begins to contract before the right ventricle. It has a longer isovolumetric period before ejection, and this is because the left side of the septum is depolarized by the conduction system first. The right ventricle starts to eject blood first because much less pressure is needed to open the pulmonic valve than the aortic valve. The afterload on the right ventricle is far, far lower than it is on the left. So the left has to develop more pressure before ejection is possible across the aortic valve. And the left ventricle completes its ejection before the right, even though it must eject against a much higher pressure. This is because it's more muscular. It has a greater ability to develop force vigorously. Here is the only part of this slide that I really want you to know. First, heart sound S1, which marks the beginning of systole. Notice its coincidence with the QRS complex. And this sound is emitted by the closure of the mitral valve and the tricuspid valve, the big AV valves. Remember those bass drums? And these AV valves close almost at the same time, not quite, but very close together. So S1 is normally heard as a single low-pitched thud. No splitting can be detected. However, it is possible to hear S1 splitting very clearly in patients with bundle branch block. Think about why. Bundle branch block, either on the left or right side, would delay the excitation of one side of the ventricle because it's not conducted on that side by the ventricular conduction system, the bundle branch. And that delays the onset of right or left ventricular contraction and separates the mitral closure from the tricuspid closure. And in this pathological circumstance, we can sometimes hear splitting between S1. The second point to note is that the opening of valves does not normally make sound. So this is the point at which the pulmonic valve opens, and this is the point at which the aortic valve opens, and both openings allow for ejection. Now, the closure of the semilunar valves, the aortic and the pulmonic valve, are often separated enough in time to hear them as separate and distinct. And it's often possible to make S2 split further by asking your patient to breathe deeply as you listen with a stethoscope. A deep inspiration, you may recall, increases the return of blood to the right side of the heart. And now, because the right side of the heart needs to pump more blood on the next beat, this delays the closure of the pulmonic valve and accentuates the splitting. Let's see that here. So on inspiration, a surge of extra blood will flow into the right ventricle, and it will therefore take the right ventricle a little longer to complete ejection. And that will delay the closure of the pulmonic valve just enough to accentuate the splitting of S2. And in your Heart Sounds online tutorial, there will be an example and further information on S2 splitting. Don't worry about all of the asynchrony between the right and left atria and ventricles. The point of this slide was really just to show you the origin of S2 splitting. Okay, now you're all very comfortable with the Wiggers diagram and the changes in pressure and volume in the left side of the heart over the course of a cardiac cycle. But these changes can also be illustrated in what's called a pressure volume plot, or a PV plot. Suppose we measure the changes in the left ventricular volume over the course of a single cardiac cycle. And how could we do this? How could we measure left ventricular volume over the course of a cardiac cycle? The echocardiogram can measure the silhouette of the ventricular chamber throughout the cardiac cycle, and it can calculate the volume of that change. So we'll plot that on the x-axis here. And at the same time, we'll measure left ventricular pressure using a pressure-tipped catheter in the cath lab. And if we plot the pressure as a function of volume, it forms a closed loop. Let's take a look at that loop. We'll begin here at the start of diastole. The ventricle contains only a small amount of residual blood, about 70 mils, and that would be end systolic volume. Notice that the pressure is very low. The ventricle is very compliant, distensible, so as the blood surges in to fill the ventricle, the volume increases with very little increase in pressure. Again, because the ventricle can expand to accommodate the incoming volume of blood. At this point, the ventricle contracts, and both ports of the ventricle are momentarily closed, so we have no change in volume, but an increase in pressure. Remember, that is called isovolumetric contraction phase. This little guy is trying to push the blood out of the ventricle, but the port is closed, so we build pressure without a change in volume. The pressure rises to the point where it exceeds the arterial pressure, and the aortic valve opens to allow ejection. The ventricle continues to build pressure, and volume is decreasing with ejection. Eventually, the ventricle begins to relax, and the pressure in the ventricle decreases below the pressure in the arterial tree, and the aortic valve snaps shut, and we begin isovolumetric relaxation to start another cardiac cycle. So this is a PV loop. So let's go back and put some labels on this and see if it all makes sense. First of all, end systolic volume would occur right here, right? And that would be about 70 mils. End diastolic volume would be right here, and that might be 140 mils. The point at which the aortic valve opens and ejection begins is diastolic blood pressure. That's the lowest blood pressure during the cardiac cycle. And the peak arterial blood pressure is achieved during the ejection phase. So this would be systolic blood pressure. And finally, the difference between the EDV and the ESV would be the stroke volume right here. Now we can model various pathological states in the heart using a PV loop. For example, here is a heart in early failure, and it has undergone an initial phase of adaptive remodeling where the ventricular wall thickens, becomes more muscular. We shall see that this process becomes maladaptive in later phases of heart failure, but consider how well this ventricle would expand to accommodate the inflowing blood. Do you think that this thick, stiff ventricle would have a high compliance or low compliance? It would have a low compliance, a low capacitance, because it is thick and stiff and it does not easily expand to accommodate the inflowing blood. So if this is the normal PV loop in a healthy heart, this might be the PV loop in a hypertrophic heart. Notice that as the blood rushes in to fill the ventricle, the thick, stiff ventricle does not easily accommodate the inflowing blood, and we see an abnormal rise in pressure. And we shall see that this can also occur in an ischemic heart. More on this later. Okay, as you might predict, the cardiac cycle is affected by heart rate. At a resting heart rate of 60 beats per minute, remember diastole occupies about 2/3 of the cardiac cycle, and systole the remaining third. So the heart spends about 2/3 of its time refilling and resting, and 1/3 of its time contracting and ejecting. But what happens if the heart is called upon to increase its rate? For example, during exercise. It must curtail one or both phases of the cardiac cycle. So what happens? Well, if we increase the heart rate to what is typically a maximal heart rate in a healthy individual, about 180 beats per minute, both systole and diastole are curtailed, are shortened. But notice that diastole is shortened much more severely than systole. In fact, diastole is shortened 5 times, whereas systole is shortened only 1.7 times in a healthy heart. So what might be the consequences of shortening diastole? What happens during diastole? The heart fills with blood. As the heart rate increases, the time for the heart to fill in diastole shortens. And how might the heart partially compensate for this? Atrial kick. Atrial kick becomes important during exercise and diastolic dysfunction. Remember, at resting heart rates, ventricular filling is more than 80% complete even before the atria contract here. So the rapid ventricular filling phase may fill the heart with 60% of its end diastolic volume. An additional 20% may fill during the reduced filling phase. And finally, atrial kick, right before systole, really doesn't contribute that much. However, as we age, atrial contraction contributes to ventricular filling to an increasing degree. In young, healthy adults like yourselves, atrial kick only contributes maybe 10 to 20% of ventricular filling. As we age, the ventricle becomes less compliant, doesn't expand to accommodate the incoming blood as easily, and therefore atrial kick contributes a greater proportion of ventricular filling. In an 80-year-old, atrial kick may be responsible for topping up the ventricle with 40 to 50% of the end diastolic volume. So to recap, as heart rate increases, the time available for the heart to fill diastole becomes less and less. And although atrial contraction is of minor importance at rest, it assumes major importance in ventricular filling at higher heart rates and as we age. And this explains why patients without a functioning atria, as in atrial fibrillation, are typically asymptomatic at rest, but become breathless and dizzy while attempting to climb stairs. And finally, a little bit about heart sounds. I have revised the heart sounds tutorial this year. Here is your assignment. First, read through the heart sounds overview. It's very brief, only a couple of pages. And then you'll be well prepared to watch 3 short online videos that are available from Khan Academy. The first part is 12 minutes, the second video is 14 minutes, and the third part is 9 minutes. And if you watch this, 35 minutes videos, you'll be in great shape. I have not found any other online video through any instructional resource that even comes close to the clarity of these videos. So these are really high yield. And then once you go through these videos, test your knowledge. I have edited a heart murmurs video by Dr. Strong at Stanford, and this includes 9 minutes of instruction. He goes through 4 common murmurs, see if you can diagnose the murmurs, and then he explains the origin of those murmurs. This is also an excellent video. And if you go through the assignments, read through the overview, go through the Khan Academy videos, and test your knowledge, you will be in great shape for the Block 2 exam, for the cardiology module in Block 7, and for your clerkships in Year 3. So that concludes Part 2 of Lecture 6. Thank you for your attention.